So we will do one thing, we will do a skeletal for this particular topic. So if you see this biomechanical preparation, I want all of you, I'm sure I'm not going to give you notes of each topic. I'm going to give you a lot of clinical pictures and videos and some demonstrations maybe, but I'll give you a flow chart. Suppose a question comes on BMP. What will you write? In fact, it's not called BMP anymore. It's called cleaning and shaping. Sometimes there's shaping and cleaning because you have to shape first and then clean next. We'll talk about all that things. But the most important thing what you need to understand is structure your answer, for which, for me, it starts from introduction to conclusion, whatever the headings that can come. So I was just sitting on this question and I said, let me write my way, So I'm not going to give you other ways because I'm sure all teachers from your respective colleges have given you good notes. You can also borrow notes from each other's colleges, follow them, read them, get it from any literature that you can get. But I want you all to understand how to write a paper. I would have written an introduction that is like you're introducing a subject. You need to always do that. You need to introduce everything first. And then you write why. Every study or every question will have aims and objectives. Aim is just one most of the time. Objectives are many. What is the reason behind the question being asked? What do I need to write about that question? And then you can go into the principles for this topic, of course. Then you can go to the terminologies. You can go into the motions of instrumentation. You can go into the working length determination. You could go into techniques and maybe conclude it. In some other classification and some other question you may have a classification to write, advantages, disadvantages to write, pros and cons to write, whatever it may be. So when you get a question like this is what I would construct. This is my constructing because for me it's all about readership. I want to read it well. If I've seen that the student or the participant has written the flow chart so beautifully, has given me beautiful pictures, has labeled them well, has put a good sketch of the flow chart, I know he knows the answer well. Even though he has not got enough time, I will be for it. It's that way, I'm sure all the speakers, the examiners will think the same way. So please try and understand this point. Now, when it comes to introduction, what do you want to write about introduction? In introduction, of course, what is BMP? Why was it called BMP? First is what is called chemomechanical. There's a lot of chemicals involved and mechanical happened. Then it became biomechanical because biological aspect came into the mechanical aspect. Today they say let's not make it as only biomechanics, let's call it as cleaning and shaping. Actually, truly speaking, shaping and cleaning, but if you don't shape, you cannot clean. So the whole concept has changed. These are all newer words that's been mixed up and used up. You can call it a misnomer, you can call it as the right word to be used. That's your wish. First thing is about introduction. Give it in a small paragraph, apt and brief. Don't make storytelling to the point that if you don't know an answer, it's a different thing. But if you know an answer, I want you to give the good story to the point. Second point will be objectives. When you talk objectives, you need to say why was it asked? What are the objectives of cleaning and shaping? Or shaping rather. There are two things. One is mechanical, one is biological. What are the mechanical objectives? That's what shape it demands. A smooth flowing curve, rounded angles, a flare on different levels, keeping the apical diameter as small as practical. You don't disturb it. Follow the inner and the outer, respecting diameters and the walls and the flow of the root. These are all the mechanical objectives. Herbert Schilter gave us, right? Now there are something called as biological objectives. Why do you have to enlarge the root canal? It is true that when you clean with, say, hypochlorite or with any other chemicals, it removes a lot of bacteria from the canal. But remember one thing, for your needle to go inside there, for you to irrigate that place, you have to shape, otherwise the needles don't go. The thinnest needle is about 30 gauge. And the 30 gauge needle has to go in to the deepest portion, that is the apical end. In the roots you have three ends, right? You have the coronal end, you have the middle, and you have the apical end. At the apical end, if the needle has to reach there, you have to prepare the end to a good diameter. So now you understand there are three things to remember in this root canal. one is called the length. That's called the working length. Will come later. You have no choice. You have to enlarge till where it is. You can't be short. You can't be beyond. Second is called a diameter. End of the root has got an exit. That's called the minor diameter for us. But now it's infected. So we need to enlarge it to a certain diameter. If you have read Grossman's principle, he said, let us enlarge the diameter to about 3 sizes. Now this was just a concept. It's not a must now. You may do it 3 times, you may do it 2 times, you may do it 5 times. You clinically decide that. But you need to understand what it means. So you're enlarging the diameter a few times more. Only because to get a biological concept, which means you want to bring the dentin, which is infected on the inner wall of the root canal, to an area where it's non-infected as much as possible. That's why you enlarge it, say the initial apical file to a master apical file. That's 3 sizes. Initial apical file is the first file that binds the root canal from the entry point till the very end. Till the prescribed point. That's a snugly fitting file that goes to the full length. It's called the IAF. It's an initial apical file. Now, old literature demands that you have to do it 3 sizes more. So if the 10 number file, a K file, is binding tightly, we want you to enlarge till 15, 20 and say 25. So you stop at 25. Fair enough. In the newer concept, the whole thing has changed because argument is very simple. They say, suppose I enlarge till 25, what guarantee do I have I get clean canals? Or sometimes I don't need 25. I can be lesser than that and still have clean canals. Both arguments are correct. It also depends on either tooth vital or non-vital, infected or non-infected. So that theory is a separate topic. We're not going there. I just thought I'll give you a little clinical perspective why these 2 objectives existed. A mechanical and a biological. Biological because it is not only because of irrigation that the bacteria go out. When you do a cleaning and shaping, mainly shaping, a good amount of bacteria gets out because of the dentin debris that gets cut and you are washing it out. So mechanical is still there, but it's called a shaping. That's what you should understand. So then comes principles. What are the different principles you want to think about? We'll just stick to coherence. There's crown preparation, root preparation. Root preparation was called as radicular cavity preparation. They spoke about terminologies. Now different terminologies have been used. Now we'll just cover a few of them. I just picked up some clinical slides to explain them better. Like a precurve filing, maybe apical patency, a Glidepath, a recapitulation. These are the words I saw in the books. I know I'm speaking to undergraduate students. I know I'm speaking to young minds. But if you understand this well, I think at these points are kept in your mind. Constructing a paper, writing an answer should not be a difficult thing because this is an absolute a clinical thing. If you go into some topics which are non-clinical, where there are formulas, I know you may have to mug up, you may have to by heart, you may have to study it in a very, very different way. Okay? So the next point, we'll come to this point one by one in a clinical example a little later. Motions. When you talk of motions, you need to understand again, what are the motions of instrumentation? The oldest motion was called reaming. You type into Google, type into any, dictionary, ask what is the reaming. One of the meanings will be, you're reaming a root canal space. That's how close reaming was mentioned. Basically, you're drilling into the space to remove the dentin. Okay? Filing. Filing is what you're going in and out to again cut dentin. Then it came circumferential filing. Then there is watch winding. There is balance force, envelope of motion, whatnot. We'll see if time permits, we'll cover them. Working length is another important topic because you can only work till where you can go. Like I said, first it was length, then was diameter, third is known as taper. Taper is less important when it comes to length, diameter and taper. Length you have no choice, diameter you have less choice, taper you have all the choice. Do you want to make it a big flare? Do you want to make it less flare? Choice is yours. Follow whichever concept you want, everything works. Glide path. So if you see here, what do you mean by glide path? Again, as undergraduate students, don't get confused. Don't have to worry about all this much. But glide path was a concept. You know why it came? It came because X-rays are 2D. The radiograph that we take are 2D pictures. And tooth is a 3D. So what we need is, we need to work in a 3 dimension or a third dimension which we cannot see. So to get the glide path, when you make a radiograph, you can see the right and the left, that is mesial and the distal. You can see the down and the top, that is the crown and the root. But you cannot see the in and the out. Okay, that's the third dimension, which means you cannot see the cheek and the palate. That's the third dimension, for which sometimes we need CBCT, like a scan, like a 3D. I'm not going there. What you need to know simply is, what is a glide path? Glide path is nothing but you need a hand file which will travel from the entry point of the access cavity till the end of the root canal in a smooth fashion, repeatedly, passively, systematically, every time. And that's what is needed. And preferably a glide path file should be a stainless steel file, because I want a reproducible glide path. I want to register the impression of the canal. Because when you take the file out, when it curves palatally, when it curves buccally, the file when you take out, it shows me the direction of curvature, which never comes on a 2D, never comes on an X-ray, never comes on a radiograph. That's what glide path will teach you. So what you need, simplest is the smallest file. When I say smallest, of course you will argue and tell, yeah, 6 is small, 8 is small. Correct, it's small. But the standard file that 10 number offers you with resistance, the others don't. So I need a 10 number file to go up to where you can go, if possible to the full length of the root end, that's here. That is known as a full glide path, a passive glide path. It has to be a super loose number 10 file. That's how it is. Now, if that you can get, I think the root canal becomes easy. Because you know the path, you know the direction of its travel. It might be a short canal, long canal, curved canal, narrow canal, wide canal, straight, anyway, or a block canal. So you know, you get an idea of how to work. So they are called scouter files, like the number 10 file or the small files are called scouter files. Like I said, it's for undergraduate I'm talking, so I don't want you all to get worked up with all these references. But these are the people who develop these concepts. The good clinicians, Richard Munns, or your Cliff Ruddle, or John West, they are the people. So I'm not going to read the slides here, but what you need to understand is, you need different types of files for different cases. So every root canal may not be simple. Some may be simple, some may be a little difficult, some may be not very, very difficult. So we've classified them as simple, not so simple, or not at all simple. So different types of files to get the path inside. So these are hand files. In the earlier days, we did root canals with only hand files. We put a 10 till the file becomes loose. We took it out, washed it, put a 15, again did it, put a 20, again did. We went on doing it till say 40 or a 50 or a 60 number size. 60 is nothing but 0.60, the 60 size apical diameter, a 0.6 cross-sectional diameter at the apex. But these were all hand files called 2% files. Leave it at that. I'm just trying to give you a concept. Because I told you a steel, you can pre-curve the file. So when it's a hand file, you can, don't write as a night type, please write as a steel file. Even though you get night type, that's not for routine endodontics, it's for something else. Okay? So you pre-curve the stainless steel file and we'll use it in the root canal. The 10 number files you can pre-curve. Like, I only want to speak about patency filing. You know what patency means? It's nothing but purposeful placement of an 8 or a 10 or a 15 number file little more than the tooth length. That is apical diameter, minor diameter, not the major diameter. You had words like step back, a step down, or a step back and a crown down. One was conventional preparation, we prepared to whatever sizes. There are other preparations of reciprocations and crown down, ultrasonics, I'm not going there. What we'll speak about is step back and step down. Step back is what? I've gone to the root end, say size 25, but 20 millimeters length. My working length is 20 millimeters and I've enlarged till 25. For some reason, there are multiple curvatures and it is a tight binding canal. I'm getting stuck somewhere in between and I'm not going to go there equally every time, systematically, serially. For which what we'll do is, we will start removing the restrictive dentin above the apical end. So this was at 20 millimeter length, 20 size or 25 I said enlargement size. So I will take a 30 size file, reduce 1 millimeter. So 30 size file at 19. Clean the cavity again, recapitulate, patency filing, everything. Take the next file at 35 at 18 millimeters. Again clean it well with all those irrigants, hand files, smallest files, apical clearing files, patency files, Precurve files, everything. So 20 becomes 19, 19 becomes 18 in length. But what happens, diameter was 25, becomes 30, becomes 35. When you go to 40, you make 17 millimeters. When you make 45, you make 16 millimeters. You make 50, you make 15 millimeters. That way you are stepping back, which means you're trying to remove all the resistance that you got in the root canal because of any reason to clear your pathway for a better cleaning, for a better obturation and a completion of a root canal. This was the earlier concept. We still follow it. Believe me, we follow it. About 10 or 20% of the times, you still need it. You have no choice. But today, what's very, very popular is what crown down technique is all about. Which means we start from the top. We start with a larger file, a bigger file, a much bigger tapered file. And you know what? We are working on the sides and not the tip. The tip doesn't cut, only the sides cut. And then we'll use the next file to go deeper. Sides cut, and next file to cut, and next file to cut. So it keeps going that way. So what happens at the end of it is, you're only going to the root end with that one file or two files or three files maximum to prepare the root end. So that's a pure crown down technique. Just to revise all what I said, we divide the root into 3/3, the coronal third, the middle third, the apical third. I will use a larger tapered instrument. Just an example, okay? Say 8 taper or 10 taper or 12 taper. It doesn't go anywhere far. It is just on the top. But it opens. When it opens, I can see the next level. I'll take a smaller file than before. Say 6 to 8 tapered file. I'll open the middle. Then I'll use my hand files and go till the root length. I'll make my working length. And then I'll start working on the root end. There I'll use maybe 4 or 6% files. These are only tapers. Then I will say I'll end at 25, I'll end at 30, I'll end at 40. That becomes the diameter. So length of the root canal is important. Taper is not so important. Diameter is also important. Okay, so understand this concept. This is about root canals. Now when shape you do this. So entry, what happens? Coronal flare. Why do you need to flare? You don't need to all the time. If you have a large canal like a front tooth, an anterior, like a canine or a central incisor maxillary, you don't have to. A distal root of a molar, you don't have to. A palatal root of a maxillary molar, you don't have to. Where you need to is all these obstructive, restrictive dentin. Like you see here, this is the point. There are many a times on a mesiobuccal root, it becomes more difficult. That's when you will try and do this. You will use that files to brush it out and remove the restrictive dentin. That's called a pre-flare technique or coronal flare technique. By removing that restrictive dentin, your root canal becomes that much more straighter. So for which you have various rotary drills from different companies. Use whatever suits you, whenever suits you. But today you are writing a paper. To understand that much. So you need to understand one more thing. How far to go? You have to go till the minor apical diameter. That's the constriction that we have talked about. Because endodontics ends there. Beyond that is a periodontium. It's all about your cementum. It's all about periodontal ligament and the rest.